I look forward to talking to you about this subject because, as Renee said, um, this is really where I started out at back in 1984, when I became interested in older adults in particular, because of what I had read about the difficulty that the elderly experienced in nursing homes and various other settings in the United States. So it was at that time I became interested in geriatrics. And in particular, I enjoyed seeing older adults. I was initially in family medicine, so I kind of enjoyed, delivering babies, but, I really didn't like to take care of children. I was trying to look in their ears, with the ophthalmoscope, and they would fight and scream. And at some point, I just said, the heck with this. I like older adults who are generally appreciative of your care. And so I decided to focus in on older adults. And in particular on religion in older adults, because that seemed to be very important to them. So I'm going to talk a little bit here about starting out with some early books that I wrote, and then start looking at the research on the topic. So this was my first book back in 1988, and this just gives you the the content, the table of contents. Starts out with measurement, and then goes over religious beliefs and mental and physical health and religious rituals, religious experiences, religion and social stress, and the social stress model. I provided some cases, had a chapter on the social gerontologist perspective by Barbara Payne, who was a giant in the field of religion and social gerontology at the time. The ministerial perspective by Mona Smiley, who was I believe she was a sister, a Catholic sister. And then the implications, and finally I included in the appendix a measure of religious involvement, the Springfield Religiosity Scale. So that was my first book. Then a few years later, I wrote this book, Aging and God, Spiritual Pathways to Mental Health in Midlife and the Later Years, starting out with the history of psychiatry and religion, talking a bit about Sigmund Freud and his somewhat antagonistic views towards religion, and the conflicting approaches to mental health that characterized the field between religion and mental health care, and then talked about theories of human development and Fowler's stages of faith development, and provided my own theory of religious faith development in later life, and then looked at the use of religion in coping, and then presented a bunch of cases of older adults at the Veterans Administration Hospital in Durham that I had encountered early in my training, on how they cope with the stress of being hospitalized and sick. And, just really covered a lot of information in that book: alcoholism, sexual dysfunction in later life, and religious involvement, family and bereavement issues, religious conversion, hope for the dying, suicide, physician-assisted suicide, just a wide range of comments. Anyway, so those were my two first books that I wrote. And so this is what Psalm 90:10 says: the days of our years are 80 years and 10. And if by reason of strength they be 80 years, yet is their strength labor and sorrow, for it is soon cut off, and we fly away. So three score years and 10. So I'm right there. I'm right there at that 3 score years and 10. And I'm hoping that with, that I could get to 4 score years and maybe beyond. But in any case, this was written in somewhere between the 5th and 10th century BC. And I believe that the average length of life that historians say, it was about somewhere between 25 and 30 years old. But apparently some people did get up to 70 years old and even 80 at that time. Now, just a little bit about the changes in the brain with normal aging before we dive into the religion and health research. The brain shrinks in volume, especially the cerebral cortex, about 5% per decade after the age of 40, and really starts to pick up in shrinkage after the age of 60. The least affected parts of the brain with aging are the occipital cortex, which controls vision, and the temporal lobe, cerebellum, and hippocampus are in between the cerebral cortex and the occipital cortex in terms of shrinkage with age. Most of this shrinkage is due to gray matter, neuronal cell death, as well as changes in the spokes that go off of these neurons, the spines and synapses. And it's thought that this dendritic sprouting may compensate for some of the cell death. As the brain adapts to the cell death, the projections from the nerves seem to become more complex. Also, the white matter that surrounds many of the long nerves that go down through your spinal column, they seem to also begin to deteriorate after the age of 40. So things start to deteriorate a lot sooner than many of us might think here in terms of age. Now, cognitive changes, they take, what are some of those changes? Well, it takes a little longer to commit new information to memory, to recall names and numbers with increasing age. This is due to slower processing of information. Also, memory for facts, which is called semantic memory, and memory of personal experiences, which is called episodic memory, begin declining after age 60 in particular. Procedural memory, which involves remembering, like how to ride a bike or tie your shoes or drive a car, remains largely intact. Working memory, though, to hold information in the mind, such as phone numbers and passwords and location of your car, also declines after the age of 30, believe it or not. So, and then finally, it's harder to divide your attention as you grow older. In other words, it becomes more and more difficult to multitask and to, for example, hold a conversation while driving becomes more difficult. So this is an excuse that I use when my wife tells me I'm not listening to her while I'm driving. So I just say, well, that's because I'm getting older. This is just kind of natural. She doesn't buy it though. So anyway, okay. So let's start going here with some of the research. So, this little thing here, dang. Now, where was I going? Superman in his later years. Okay, so that kind of summarizes it there. Okay, so what about religion as a coping behavior? As I said earlier, that's kind of where I started looking at the role of religion in health. It seemed that among older adults, they were using their faith a lot to cope with their illnesses when they were in the hospital, when I was seeing them in outpatient clinics. They were praying. That's when I would ask them, how are you coping with all of these health issues? They would talk about their faith, praying, their religious community, their clergy, all of those kinds of things. And indeed, it does seem as though religion is used to cope with common problems in life, particularly during later life, as the stressors begin to increase in number and the losses begin to mount. Religion is often used to cope with the losses and other challenges such as uncertainty, fear, loss of control, and then discouragement and loss of hope. Now, what's interesting is that despite the fact that losses increase with later life, as people get older, the losses in terms of health and independence and loved ones, despite that, depression is actually less common than in earlier years. And in fact, depression seems to peak in midlife. And also psychological well-being is at its low point in midlife and actually increases with increasing age. Might that have something to do with religious belief? Well, we'll see. The reason I'm pausing here is because my Zoom has a bar at the bottom that interferes with my ability to see my slides. Okay, so research on religion and mental health and aging. A lot of this research is found, as Renee said, in the handbooks, and the one in particular that is forthcoming either later this year or in 2022. That will have an update on the best research that has been done at all ages, but a lot of that research has been done in later life. There are also a couple of articles now that you can download from the British Journal of Psychiatry Advances that are on the research and the clinical applications, and those are shown down here. Depression, let's start out with that. And this is based on a systematic review in the second edition of the handbook. So a lot of this research in the systematic review was conducted prior to 2011. So it's fairly old, but I'm going to also update some of that research with some new studies that have come out recently, particularly in older adults. So most of the research prior to 2011, or at least the majority of it, or about 2/3, found that religious people tend to be less depressed, and if they do become depressed, they recover from it more quickly. So let's look at some earlier studies on religion health. This was a study I did back in somewhere around 1988. And I said this was at the Veterans Administration Hospital. These were all older adults. And we used the geriatric depression scale. And we looked at religious coping, the degree to which a person depended on their religious faith to cope with their health problems. And so you can see here that the rate of depression among those who had low religious coping was just about double, or a little more than double, compared to those with high levels of religious coping. This was in Durham, North Carolina. Now, we repeated that study at Duke Hospital, again among older adults. These are all adults over the age of 60. And this time we started out with, first of all, including only people who had a depressive disorder. So we used the diagnostic interview schedule to diagnose a depressive disorder. And we followed these individuals for about 12 months, including after they were discharged from the hospital back home. And what we found was that among those who were depressed at the start of the study, which was everybody, those with low religiosity seemed to remain depressed longer compared to those with higher religiosity. And this difference was very strongly statistically significant, despite the fact there were only 87 patients in this study, and it was independent of other risk factors. We then repeated this study later among people over the age of 50. It was a multi-site study. It was actually we started out with nearly 1,000 hospitalized patients with depression, with a significant depression. It was actually the largest study at that time that had ever been done among hospitalized medical patients looking at depression. So by itself, not even considering religion, it was the largest study that had ever looked at depression in the medically ill at that time, which was the late the early 2000s. So of the 845 patients who actually completed follow-up, again, the more highly religious were recovering more quickly from depression, independent of demographics and physical health and psychosocial stressors and psychiatric predictors at baseline. So that really started me thinking, about this relationship, that in fact, perhaps religious belief and practice were protecting these older adults despite all the stressors that they were going through. And again, these are all studies in the United States. So now here's another study, interestingly, and many people say, well, okay, sure, that's for older adults. That's for older people. That might be true. What about younger people? So I'm just throwing this in. This was a 3 to 6 year follow-up of nearly 10,000 young adults, average age 23. And this was done by this came out of the Harvard School of Public Health. And what they found after controlling for 24 other covariates, as well as correcting the p-values using the conservative Bone-Ferroni correction, because there were several other outcomes they looked at, there was a 30% reduction in the likelihood of developing a depressive disorder over that 3 to 6 year period among those attending at least once a week compared to those who never attended services. So this is young people. This is like average age is 23. So these relationships are not just limited to older adults. Okay, so here's a famous study. Many of you have heard about this. Is out of JAMA Psychiatry, one of probably the top biological psychiatry journal in the world, looking at neuroanatomical correlates of religiosity and spirituality. So this was done at Columbia University up in New York City, and they looked at the structures of the brain structure among individuals at high risk for a major depression. So these individuals were at high risk because their parents had a major depression, and it was felt that they had inherited some of the genetic risk for depression. And what they had found was that the brains of these individuals at high risk for depression were actually different compared to those who were at low risk for depression. And they found that there were multiple areas of the brain that were actually thinner, that seemed to be shrunken across the brain, particularly the cerebral cortex, among those at high risk for depression, perhaps for some genetic reasons. So they divided these individuals at high risk into two groups: those who indicated religion or spirituality was very important to them, and those who indicated that it was not important or only somewhat important. So here is the finding. You can see here that here are the areas. The areas in red indicate reduced cortical thickness. This is actually, sorry, this is a structural MRI, not a functional. It's a structural MRI study. And so you can see among those for whom religion is not very important, you can see all the red areas of shrinkage across the left, right, medial, left, right, medial, all throughout the brain. So, but now look at those for whom religion is very important. Look at there's a whole lot less red over here. also compare those, and then those. So there seems to be a lot less shrinkage among those for whom religion is very important, which is kind of a remarkable finding. It suggests, it doesn't prove, but it suggests and would be consistent with the idea that perhaps religious involvement may actually change brain structure, particularly among those at high risk for depression. Now, of course, I just said this does not prove it because of the design of the study. I believe this was retrospective. Okay, so what about the most feared consequence of depression, which is suicide? So this is a study, again, out of the Harvard School of Public Health. They've been following 90,000 women for 14 years in this particular study. And what they found was that the incidence rate of suicide, that's actually completed suicide, was 7 times higher among those who never attended religious services compared to those who attended at least once a week. And even after controlling for everything in the book, they still found that the suicide rate was 84% lower among those who attended religious services at least once a week compared to those who never attended. Now, this is 90,000 women followed for 14 years. These are all nurses. So these are individuals who are well educated and who answer these questions on these follow-up surveys very, very accurately. And so that is why this is an important study, at least in the United States here. Again, published in the top psychiatry journal, biological psychiatry journal out there. Okay, so we go on. Now, this is a study, interestingly, this is actually the same cohort of women, but this is expanding it out to include death, not just to suicide, but also to alcohol and drugs, excessive alcohol and drug use. So this is deaths from suicide, alcohol, and drug use among women. And 66,000 women, controlling for 25 demographic, psychological, social, and physical health correlates. They even remove from the analysis people who are depressed at baseline or have any problems at baseline that may lead to their early death. They excluded all of those individuals, and they even control for earlier attendance at religious services. So they really did everything possible to not find a relationship here. But despite that, the likelihood of dying of a death of despair among those women attending at least once a week was nearly 70% lower compared to those who never or almost never attended religious services. Religious services, as Ellen Idler was talking about, is one of the strongest predictors of health outcomes, both mental and physical. This is among men. Now, this is not the nurses' health. This is among male healthcare professionals. And here you see a drop of 50% in likelihood of deaths of despair among women. And there is a P for trend. Now, what P for trend means is that there's actually seems to be a dose effect response, which adds to the argument for causality. So you can't, with the observational study, you cannot prove causality, but using the analytic techniques that were used here, you can get fairly close to it. And in particular, you're looking for this P for trend, and that was present in this study. Well-being and happiness. So it's not only the negative mental health that seems to be less common, but it's the positive emotions that seem to be more frequent among older adults who are more religious. In the vast majority of studies, as you can see here, here's a study that it was actually one of the first studies that I published on on religion and well-being in older adults. That was back in 1988. It was a study that was completed in 1985, actually. And it was, I forget the number, it was about 700 or 800 people, I think. It was a fairly large sample size. You can see here that whether the religious variable is church attendance or intrinsic religiosity, you find an increasing level of well-being with increasing religious involvement, but particularly for intrinsic religiosity. It's true for church attendance, but intrinsic religiosity more relates to the depth of the person's religious faith and commitment than it does to institutional religious involvement. Okay, so now here's a more recent study. This is again, this is among younger people, actually among adolescents. And so it's also true among young people. This is, again, this is coming out of the Harvard School of Public Health, published in the American Journal of Epidemiology, which is, one of the top public health journals that are out there. And these young people, average age 15, were followed, for I don't know, let's see, 1999 up to 14 years. And again, what they found was that those youth attending religious services more often were significantly more likely to experience life satisfaction when, lots of other covariates were controlled for. And that was also true for positive affect. So it was, and you can see that, for those attending more frequently, it's nearly double the beta. Now, these are not huge betas, but, they're after controlling for everything in the world and after Bone-Ferroni correction. So in any case, it's, and you see a bit of a dose effect response here as well in terms of positive emotions. So let's look at social health. Social support, more than 80% of studies show that religious people have more social support. Here's a study, again, the Nurses' Health Study, average age 47, then followed for 7 to 12 years. And they found that social integration was significantly related to attendance at religious services. And again, you see this dose effect response, and where attending weekly or more often has more than double, doubled the effect that attending less than weekly does compared to never. And then here is another study. This is a 10-year follow-up of older adults. So now we're talking about older adults, average age 69, followed over 10 years. Again, the same study. This is a study I encourage you to get. I think you can download it for free in the International Journal of Epidemiology. This is a great study. They have multiple health outcomes. Again, this is the Harvard School of Public Health. So they're just using immaculate statistical methodology that is beyond question, really. There have been no critiques of these studies either coming out of Harvard, simply because they're done just without, there's nothing to criticize about them. They're done so well. So again, among older adults, you see the same effect. You see a bit of a dose effect, and you see that the strength of the effect is strongest among those who are attending services at least weekly. Now, does this explain the effect that religion has on mental health? Just simply they're more socially integrated? It's a common question. The answer is no, it does not explain it. It explains part of it, about 25% or less of the effect that religion has on mental and physical health, but it certainly does not explain all of the effect. Loneliness, again, among these older adults, in 14,000 older adults, followed for up to 8 to 10 years. Again, you see loneliness that is lower among those older adults who are more involved in their religious community. Now, this is a study looking at, we're talking about social support, looking at marital stability. So this is actually, again, among the nurses. And this is 66,000 initially married nurses. And they're looking at the time to divorce or separation using hazards, proportional hazards regression models that are controlling for, again, 24 different sociodemographic and health correlates, including prior religious attendance. And they're looking at then what effect religious attendance has on that over time. You can see here, again, there is a P for trend, such that very progressively, and these confidence intervals are way below 1.0 here, particularly for those attending religious services at least once a week, or or fairly frequently. Let me see what that, yeah, once a week or more than once a week. Okay. So it does seem that, and having a spouse as you get older is really pretty important in terms of support. It's tough to be all alone, and getting older and having lots of health issues if you don't have somebody to kind of share that with you. And it does seem as though that religious attendance in particular seem to protect marriages. Now, here is a kind of a complex figure here, but it actually looks at several generations. And this is not out of the School of Public Health at Harvard, but it's in a fairly good journal here. And, it looks like here is religiosity. G1 is the parent. G2 is the adolescent. So it's 2 generations. You can see here that parent religiosity predicts adolescent religiosity, and it also predicts positive marital interactions over time during the time that the adolescents were adolescents, and also it predicts positive parenting during the time that they were raising their adolescents. And all of this then affects the religiosity of the adolescents when they get older, during adulthood, and it affects their parenting practices as well. So it seems as though that the effects that religiosity has in parents transmit to their children when they become parents in terms of how they raise their children. So that was kind of a neat study I thought I'd just show you. And it has to do with aging, 2 generations. Let's look at behavioral health. So in general, religion is just related to healthier practices, healthier lifestyles. They're more likely to exercise. They're more likely to be physically active. They're less likely to be physically active in activities that can cause sickness and illness like sexually transmitted diseases. So less extramarital sex, safer sexual practices, fewer sexual partners, all of which will affect the transmission of not only venereal diseases, but certain viruses that can lead to cervical cancer as well among those who have multiple sexual partners. Now, in terms of weight, that's a little bit less clear. It seems as though religious people eat too much, basically. They eat a better diet, though. They just eat too much of that diet. And so they end up sometimes being overweight. So in any case, that's that. Now, what about cigarette smoking? If we could reduce cigarette smoking, we would significantly reduce chronic lung disease, incidence of lung cancer, lower blood pressure, reduced coronary artery disease. We would just reduce a whole spectrum of physical health problems that are killing people who smoke. Those who are more religious are less likely to smoke. And that's even true here in North Carolina, believe it or not. North Carolina produces more tobacco than any other state in the United States except for Kentucky. But despite that fact, those who attend religious services in North Carolina, older adults in particular, are less likely to smoke and less likely to have a history of smoking. Now, this is a study out of Europe. We've been talking about US. This is out of Poland. And this was a 4-year prospective study of 6,400 adults, average age 49. And again, multiple covariates were controlled. So the likelihood of smoking in this prospective study goes down progressively with increasing frequency of religious attendance, such that there is about a 55% reduction in likelihood of smoking over time among those who are attending more than 4 times religious services, more than 4 times a month. And you know what I'm doing here? I'm also providing you with citations that when you do research, when you apply for grants, when you try to finish your dissertation, these are the studies that you're going to want to cite when you're in your research that's looking at religion and health. Okay, next is physical health. So let's look at that. So here is a study out of Iran. Okay, so this is a nice study. It's a case control study out of Iran, and they matched 190 hospitalized patients with coronary heart disease. They matched them by age and gender with 383 controls without heart disease. They used logistic regression to control for all sorts of things, you know, all sorts of medical conditions that increase risk of coronary heart disease. And they measured religiosity by religious beliefs. And you can see here that those in the highest quartile of religious belief are 80% less likely to have coronary heart disease compared, you know, in this case control study. And even when they look at this overall, not just looking at religious belief, but more looking at multiple indicators of religious involvement, including religious practices, again, you see a 70% reduction in likelihood of having coronary heart disease. Again, this is cross-sectional, and this is a case control study. Now, what about high blood pressure? Here is a study. This out of, again, Harvard School of Public Health. This is the Nurses' Health Study. 44,000 women with no high blood pressure at the start of the study, then followed for 12 years, looking at the rate of development of hypertension. So among those who never attend religious services, you find that that's the comparison group. And, you know, you see a significant reduction in likelihood of developing hypertension here. And again, there is a P for trend that is significant. Again, a dose effect response and controlling for just everything in Cox proportional hazards regression models that's looking at time to development of hypertension. Okay, and then consequently, we know that hypertension leads to cerebrovascular disease, right? You know, stroke and all of that. And this is what the Harvard group, School of Public Health, this is a 16-year prospective study of these 74,000 nurses, and including controlling for everything under the sun, finding again that there is a significant reduction in likelihood of cerebrovascular disease among those who attend services at any level, you know, compared to those who never attend. And again, the research methodology here is absolutely immaculate. Now, this is cardiovascular mortality overall. This is again by the same research group following nurses for 16 years. You see here that cardiovascular mortality among those attending services at least more than once a week is about 25% lower compared to those who attend less than once a week, or who never attend, sorry. And then again, there is this P for trend here. there is this, with increasing religious exposure, with increasing religious exposure, there is decreasing cardiovascular mortality, which is quite consistent with the earlier slides, looking at this, less cerebral vascular disease, less hypertension, less coronary heart disease. So it makes sense that cardiovascular mortality would be lower, and it is. And that's also true in Israel when you do studies looking at the effects of going to synagogue, practicing Jewish rituals in the home, and religion being important enough to raise your child in a religious teaching environment, education level. So here's 10,000 men followed over a quarter of a century, finding significantly higher levels of survival, less deaths from heart disease compared to non-believers in Israel. This is survival after open heart surgery, showing that at Dartmouth Medical Center, this is done by the Dartmouth investigators, it's an older study, finding that the combination of low social support and low religious coping is a deadly one after open heart surgery, with rates of mortality, with a difference of mortality of 14 times. That's the odds ratio in terms of the percentage of people dead following open heart surgery. These are all older adults in this particular study. Now now let's get into memory. So let's look at memory in older adults, particularly among those with Alzheimer's disease. So here's a 12-month prospective study of 64 patients with Alzheimer's disease, and they are looking at they're measuring their religiosity, and they're looking at changes over time in the mini mental state exam, in other words, of cognitive functioning. And what they found in this particular study is that the likelihood of decrease of experiencing a 3-point decrease in the mini mental state exam was almost 7 times higher among those who had low religiosity compared to those who had high religiosity. Okay, so we're starting now with people with Alzheimer's disease. Now this is a study out of Canada. This is out of a neurology group in Canada, in Toronto, I believe. Yeah, Toronto. Again, controlling for multiple, baseline cognition, age, gender, education, finding that that decline in mini mental state over time is significantly correlated inversely. There's less of it among those who are more spiritual and religious, and in particular among those who pray and read scriptures and do this private religious activity. That's where the largest inverse relationship is. So in any way, these are partial correlations, but these are over time. This is a 12-month prospective study. Again, we're looking for causality here. So this helps. When you have a prospective study, it helps because you're measuring religious involvement prior to the changes in cognitive functioning. Now, this also apparently applies to physical functioning as well. So here we have those who never attend religious services in the smallest line, and those who attend more than weekly or attend weekly. And clearly, if you look at this is, again, a 3-year prospective study, 784 people age 65 or older. Again, you find that those who attend services more quickly or more frequently, they have the least amount of impaired instrumental activities of daily living compared to those who are never attending. And in fact, that disability increases more rapidly as well over time. Okay, so here is another study. This is in I guess this is in Europe. Yeah, this is a European study showing the same thing. Many people say, well, you US guys, yeah, that's Americans. But what about Europe? Well, here's Europe. So, what else is there to say? Likelihood of developing ADL impairment with age. Again, I believe this is a prospective study. Yeah, 9-year prospective study, 14,000 older adults in Europe, finding that, there is a lower likelihood here, significantly lower likelihood, not a huge effect, but still a significantly 25% lower likelihood of developing ADL impairment over 9 years compared, compared to the more religious. More religious means that they reported praying, taking part in a religious organization, and having a religious education. Okay, so anyway, so that's that. And immune and endocrine functions seem to be better among older adults. Now, this is important during the pandemic because you want your immune function to be as strong as possible to prevent being infected by this COVID-19 and to recover from it if you are. We did one of the first studies showing that religious involvement was related to immune functioning. This was a large study of older adults, 1,700 older adults. And these are cross-sectional findings, lower levels of inflammation, which is an indicator of immune functioning. And here's another study. This group is looking at HIV, people with HIV, 12-month prospective study. Again, looking at viral load. This is the concentration of the HIV virus in the blood. And comparing those who attend services, there is a 50% lower level of viral load among those who are attending religious services at any level there compared to those who are not attending services. Again, this religious attendance seems to be one of the factors, or seems to be the primary factor. Now, this is looking at death rates from cancer. This is among young adults. This is among nearly 10,000, average age 23. Look at the risk ratio for a cancer diagnosis. Compared here, the risk ratio is 63% lower likelihood of developing cancer in youth among those who are attending at least weekly. And then cancer mortality among the nurses was also lower in the Harvard study. And here is another study. I don't think this is done at Harvard. Nope, this is not a Harvard study. But again, another study. This study, if you want a large effect size, this is 580,000 US adults aged 30 or over, followed for 15 years, showing that the likelihood of developing cancer is 10%, higher among those who are attending services less than once a month. And if you look at Black women, you find that it's a third higher among those who are attending less than once a month compared to those attending once a month or more frequently. I want to speed up here, and I'm not doing so good here, but okay. There is actually a biological mechanism to explain why religiosity may be predictive of developing cancer. And it appears that there is a gene that we all inherit that's called the cancer suppressor gene that suppresses the development of cancer. And it looks like religiosity is related to more activity of this cancer suppressor gene. By first of all, greater religiosity appears to be related to less inflammation, and less inflammation is related to, or more inflammation is related to less activity of this gene. So if you multiply the indirect effects, you end up with a positive effect of religious activity on activity of this cancer suppressor gene. And then indeed, this is again out of Harvard, the Nurses' Health Study, all-cause mortality is lower among those who are more religious with a gradient of effect. And here is a study in a completely secular country of China, where 90% of older adults, this is the largest study of the oldest old that has ever been done, with over 30,000 people who were age 80 or over at baseline. And the average survival here was about 2.3 years, but they followed them over a period of about 15 years. And what they found was that, you know, that 2% that attended services, I'm sorry here, my voice activated software is acting up here. I'm going to have to get out quickly. Okay, we'll go back in now. Okay, so we're back here. So again, we find that that small number, and even if they attended services, sometimes their likelihood of dying during follow-up was lower. So it's not just in religious countries that these findings are present. It's also in highly secular countries. So in conclusion, we are all aging, young and old. Some of these changes cannot be modified depending on your genetic predispositions, family history, and age itself. Some, however, can be. Beliefs, attitudes, and behaviors. Religious involvement is related to better mental, social, behavioral, and physical health, although most of these studies come out of the US. If these findings are confirmed in studies in Europe, bearing in mind the complexity of studying these relationships in secular countries where there may be social pressures affecting religious involvement in a negative direction, then public health and financial implications may be at stake, particularly in older adults who consume most of the most expensive healthcare resources. So as religious involvement is becoming less common in many countries in Europe, particularly religious attendance, if this trend continues, public health may be at risk. So this is a public health issue, not just, you know, a minor issue that we're talking about, and in particular in Europe as the population ages. Okay, so that's it. Some fewer resources here. We have a monthly e-newsletter. Please, everyone sign up for this. It reviews the latest research. Come to our 5-day research workshop in North Carolina in a couple of months. We'd love to have you here. You know, we've got some partial tuition scholarships and full scholarships, although you have to be in an underdeveloped country for the full scholarships. But send me an email if you're interested. And there's our website. And so we've got about 5 minutes for questions. So I'll open it up now for questions.
Yeah, thank you, Harold, very much for this overview on the more medical or biological aspects of aging. There are some questions in the chat. I start with the first one. Let's see how far we come. The first one is from Suhashini from India. Are there studies to show that religiosity in early years has a bearing on their religiosity in old age and face of challenges? Would they be more religious and adopt as a coping resource as compared to those who are less religious in the early years?
Yes, the answer to that is very clear, and that is yes. If people are religious in their early years, they are much more likely. You see, in general, religious involvement tends to be stable over the lifespan. There is some increase in later life, but many people who are not religious in earlier life really don't turn to religion as they get old. They remain, they continue to use whatever coping behaviors they used during their earlier years. So if people are more religious in their younger years, then they will have that available to them to cope when stressors occur in later life. So that's the answer.
Thank you. Next one is from Arndt Pussing. Several may have lost her church and thus religious involvement because of hurt spiritual, emotional, physical, and this experience of hurt may result in depressive states. Thus, the causal pathway may be important.
Yeah, that is the big issue. The big issue is causality here, and that's what all of these Harvard studies are trying to sort out. They're trying to sort out causality using observational data. And certainly we know with regard to religious attendance that depression has an effect on religious attendance. You know, it tends to lower religious attendance. So this is a real issue here with regard to, is it religion affecting depression, or is it depression affecting religious involvement? So that is a big issue. It appears that both are actually occurring. That's what they found in the 2016 Harvard study, that there was not only did religious attendance reduce likelihood of developing depression, but depression also reduced likelihood of attending religious services. So they're kind of both interacting there with each other.
So the point is that those who are not attending might have a reason why they're not attending, not because it's boring, because of hurt. We have several stories of hurt and they are depressed. So this is a very tricky way.
It is tricky.
But is this what you just explained? I think this is reverse causality. It's called reverse causality. It's what Tyler Vanderweel really was focusing on.
Yeah, and that's why, you know, they're doing everything possible to rule out this reverse causality, especially by controlling for, you know, prior religious attendance. You know, they control for 1992 attendance when looking at 1996 attendance. So they're really looking at it prospectively, and they're eliminating a lot of people who have depression at the beginning. So they're just using everything, and they're actually using techniques that are very conservative in nature, even over conservative in terms of trying very, very hard to rule out every possibility of reverse causation. And yet they're still finding these effects despite that. So it looks like there is substantial cause. You know, you don't know, you can't randomize people, you know, to church or no church, but it looks like there's plenty of causation going on here.
Tyler Vanderweel will be presenting tomorrow. So I think we'll have the opportunity to discuss with him on this topic.
Yeah, and
so very short.
And just be aware that Tyler Vanderweel is not just a religion health researcher. You have to be aware that he is the world's top statistician looking at longitudinal data, and that statisticians all over the world refer to his books on longitudinal data analysis. So it's like he is really the guy in terms of looking at observational data and determining causality in these relationships, you know, not just in religion, but across all other areas of public health. Okay, I'll stop talking, Renee, sorry.
This was a nice spot for his lecture tomorrow. A very short question from Switzerland. Heidi Liechtis asks whether the European study comes from you presented on cognitive functioning. You know
yes.
this, otherwise.
Yeah, look at the citation. You've got the PDF, you know, of the presentation. You know, it's got the reference. So I would encourage you to go and get the study, pull the study, and then look at it. You know, if you have any trouble, just send me an email and I'll send you the PDF of the study if you have any trouble tracking it down.
Okay, thank you. It's not from Switzerland. This is what I know. And there is a last question from Alistair Appleby. Maybe he would like to ask the question himself. I've seen him somewhere. Is Alistair here? Is he listening? Okay. Yeah, here he. Maybe you would like to ask the question yourself. We don't hear you. No, it was good. It was unmuted. I don't hear him.
Can you hear me now?
Yeah,
Yes.
now we can hear you.
So it's a bit echoey. Harold, this is great, but not all. Oh, sorry.
You must have two microphones active.
Yeah. Question is, are faith communities different in their ability to create health?
It's not working. Okay, I'm going to read the question.
Yeah,
It
that's
says,
better.
Harold, this is great, since not all religious services or faith communities are the same, and there is a qualitative evidence of harm as well as of help from religious communities. Is there some knowledge of what the characteristics of faith communities which enhance health might be?
Yeah, Ellen Eidler is really the person who can best answer that question, but certainly, faith communities with a healthy form of religious teachings that, are not emphasizing, that God is always bad or punishing, and you would think that those that promote God's love and God's mercy would be the healthier community, and would promote social interaction and caring for one another. It's really a dynamic interaction that goes on within faith communities that some churches, I know my own previous churches that I've been in, you just go to church, you listen, then you leave. It's you take communion and then you're out of there. My mother, she couldn't even understand the service. She was German, she couldn't understand what they said, but as soon as they gave communion, she was out of there. And so I don't know. Communities where you have a lot of interaction and a lot of strengthening of one's religious faith, and getting together also during the week, not just on Sunday, and these more social interactions. But again, it's not all social. It has a lot to do with cognitive processes. But yeah, I mean, do you know of any social group that doesn't harm people in some way? I don't know of any. I don't know of any kind of club that you could be a member of that doesn't, in some way, you don't get along with people, you get upset by people, you get hurt by people. The fact is that people in religious communities are human beings. That's the unfortunate aspect of it, is that they're just people with all of the problems and issues, hopefully a little fewer of those problems than in the secular community, but they're just human beings. And so you got to give them a little bit of a break here.